Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you taking the time to join us today for this presentation, which is collaboratively hosted by the UNC CCCR and Duke Roybal Center. Our presenter today is Dr. Rana Hinman, a professor of physiotherapy at the University of Melbourne. Her presentation today is titled Supporting Knee Osteoarthritis Care with Technology, Research from Australia. Dr. Hinman, whenever you're ready to start, feel free.
Thanks very much, and hopefully everybody can hear me. And thanks for the opportunity to talk to you all this afternoon your time and this morning my time over here in Melbourne. Here's some disclosures. I'm supported by a research fellowship from our NHMRC, and my research is currently funded by a number of grants from a number of different granting bodies, and some of these projects you'll hear about in this presentation. Before I begin, I'd like to acknowledge the team at the Centre for Health, Exercise and Sports Medicine, where I work. As with all research, there's always an enormous team of people behind the scenes and at the front of the scenes who contribute to the work. And in particular, some of the studies I'm going to share this morning have had a lot of input and wouldn't have been made possible without the efforts of Kim, Rachel, Belinda, Tor, Penny and Alex. But as is the case with many studies, usually a large number of people, in fact, many of the team contribute. Just to give a little bit of context for the background to our research and the studies I'm going to talk about, we have a very big focus on osteoarthritis. And for many of you, you'll understand why. It's because it's a high burden chronic condition where pain and physical disability are major problems. And particularly self-management and behaviour change techniques and positive health behaviours are really vital to the success of the core treatment strategies. The core treatments for osteoarthritis really focus on education of the individual with advice and access to information, strengthening exercise and weight loss for those patients who may be overweight or obese. And these are recommended as core treatments for every person with osteoarthritis. And it doesn't really matter which clinical practice guideline you look at, these are fairly consistent recommendations. So we see, particularly with exercise and things such as weight loss, that these really are require a lot of behavioural change, and patients have a lot of difficulty engaging with these core treatments. And there's lots of reasons why. Certainly our research has shown that it can be lack of access to appropriate clinicians, and in the work that we do, that's particularly over here with access to physiotherapists for exercise prescription. But also our work has shown that clinicians often underutilise these really effective lifestyle strategies in favour of more hands-on treatments, drugs and surgery. And we also know from the patient side of things that they really have problems adhering to recommended health advice and maintaining positive behaviour change. And so a lot of our research is now focused on these treatment elements that you can see in this little picture there. So we look at a big focus is around telehealth and digital support, which I'm going to talk to you about this morning. But we have a very big emphasis on patient education and increasing patient knowledge about their condition. We have a big focus on muscle strengthening exercises, on increasing physical activity, and in particular, embedding behaviour change techniques into our interventions and into the consultations that our clinicians do with our patients. And what I want to share with you this morning is a bit of a whirlwind tour, if you like, through some of our work that we've looked at. We're looking at telephone delivery care models, video conferencing, some work we've done with SMS and done with mobile apps, and also to finish off with looking at websites and e-learning. Just to give you a little bit of a background context about the system here in Australia and how Australian physiotherapists practice. As you can see from the map, Australia is a really big country, and the vast majority of our physiotherapy workforce work in metropolitan areas. You can see that that's indicated our major cities are these dark greens, so, you know, typically scattered along the eastern seaboard here. And then there's vast areas of the country that are really remote or very remote areas. The majority of our physios work in the private sector, and at least half of those are in private practices as opposed to hospital settings. So many of them are operating in private businesses as sole traders. And our registration data shows that really this being fairly consistent since it's been collected, you know, for about the last 10 years, is that only about 6% of physiotherapists have indicated that they provide telehealth. Of course, the pandemic has changed that a lot, and for the very first time in Australia, we have seen telehealth funding for physiotherapy care. A lot of this funding is currently temporary, and we're seeing funding through the government, through our Medicare system. Most of our private health insurers are currently reimbursing physiotherapists for telehealth delivery, and that's the same with our transport accident schemes, workers' compensation schemes, and also our National Disability Insurance Scheme. And so hopefully this means that it's still a little bit uncertain what funding will remain permanent and what will disappear as the pandemic hopefully starts to wind down soon, but hopefully it is reflective of a changing landscape for telehealth and digital care over here. Now, one of our first, I guess, forays into looking at digital support was really in looking at health coaching, which is a method of patient education where the patient's seen as an active participant, and the health coach is really there to try and help facilitate positive behaviour change. And what we were interested in is looking at whether some telephone coaching by a health coach as an add-on to a typical face-to-face physiotherapy program could optimise outcomes from that physiotherapy program. This clinical trial was published a few years ago, so I'm only going to give you some highlights, and that's going to be the case with everything I talk about this morning. So I'd encourage you to go to these publications if you're interested in more detail. But for this trial, we recruited 168 people with NeoA who were inactive, aged over 50 years. And what we did was everybody received a course of face-to-face physiotherapy, but the intervention group also received telephone coaching on top of that. And the telephone coaching was delivered by trained health professionals. And the telephone calls were of a significant duration, which you can see there, the first call about 30 to 45 minutes. They were unscripted and they were sort of slotted in between the physiotherapy sessions and also after the physiotherapy sessions had ended. And we were aiming for people to have 6 to 12 telephone coaching calls over the trial, and you can see our time points for assessment there. We typically, in most of our trials, and this one was no different, we usually have 2 co-primary outcomes, with one being knee pain that we measure on a numerical rating scale, and also physical function, which we typically measure using the subscale of the WOMAC. And you'll see that through the other trials that I present this morning. Now, despite these graphs in hindsight are probably a little bit misleading, there was actually no significant difference between the groups, so that the group that received telephone coaching did not achieve any greater improvements in pain or function with respect to the between group differences across the trial. So that was somewhat disappointing. We did see, however, that some of our secondary outcomes that were particularly related to physical activity and exercise behaviours did favour the coaching intervention at 6 months. However, these generally weren't sustained through to the 12 or 18-month time point. And really, for the vast majority of secondary outcomes, there were no between group differences. So that was a little bit disappointing. And there are a number of reasons. We wondered whether that was because we hadn't trained our physiotherapists in behaviour change, and maybe what they were doing or saying in the consults may have been at odds with what the coach was saying on the phone. We did find that the patients were perhaps engaging with the telephone coaching sessions less than we'd actually hoped for, with only a mean of 5.4 coaching sessions. And from our qualitative research, we found from the patient's perspectives that they really saw this coaching intervention as this sort of standalone ingredient that wasn't really integrated or seen to be part of the physio care. And so we wondered if that played a part as well. And of course, even though we saw some benefits with adherence and exercise, these didn't translate to differences in clinical symptoms, and that really speaks to the really unknown relationship and the difficult relationship that we have between exercise adherence and clinical symptoms that being really poorly understood. So then we wondered about, well, what if we train the physios in the behaviour change support, so they're not only delivering and prescribing the exercise program, but also they're the ones that are supporting the behaviour change as well, and still with a focus on telephone delivered care. This trial was published last year, so there's lots of information in the protocol. Excuse me. And for this trial, we recruited 175 people all across Australia, aged 45 and over, with knee osteoarthritis. And what we did with this one was the control arm received a telephone call from a musculoskeletal helpline that exists from one of our consumer advocacy organisations. And it's sort of a general consult with a nurse trained in musculoskeletal conditions, really to give patients, help them navigate the health system and send them some information in the mail. What we did was we added our telephone delivered physio consults on top of that. So that's what the intervention group received. And so they had 5 to 10 phone calls with the physio in over 6 months, where the consults were very focused on education, prescription of a strengthening exercise, helping patients to develop their own physical activity plan, and importantly, supporting them throughout that and throughout the subsequent calls. And our in this trial, we trained our physios in behaviour change support and person-centred care. We work with an external consultancy to do that. I think this slide really nicely shows one of the real advantages of telehealth and digital care, which really is increasing access. So this just is a little map just showing where we recruited our patients from. And so you can see they really did come from all over Australia. What we showed here, so 6 months was our primary time point, and we saw almost not quite achieving significant between group differences with pain, but we did with physical function. However, as we see in a lot of these trials, those benefits had started to wane by our 12-month sort of maintenance time point. We usually aim to detect a minimal clinically important difference in our trial of 1.8 units with pain and 6 units with function. And so you can see that the between group difference with function didn't quite make that. However, it is somewhere within those confidence intervals. So I guess what we concluded from this trial is that there's certainly some promising evidence here that telephone delivered care can be useful and effective for patients. And particularly when we looked at the suite of secondary outcomes, we saw that 8 of 14 of those did favour the exercise advice and support group. And you can see there's a number of pain outcomes, self-efficacy for pain, and all of our global change scores, which you can see here in this slide. So certainly some evidence that telephone delivered care can be beneficial for these patients. Of course, there's a number of limitations. Our physiotherapists were unblinded in this trial. We did some sensitivity analyses where we looked at what would happen under hypothetical full adherence. And we used that, we used a proxy adherence measure that for there, which was looking at the number of consultations attended. And that in itself can be a limitation. Of course, we excluded non-English speaking patients, which is always a problem with a lot of research, and I think is particularly a limitation as well in lots of telehealth research. So we really don't know how it generalises to those populations. And being a pragmatic trial, we permitted physio consults outside the trial. And we certainly found that within the control group, I think it was about 25% of patients had went off and sought physiotherapy care. And so that in itself may have diminished the between group differences that we saw. I'd like to call out to Belinda Lawford here, whose PhD was embedded in this trial, and she did quite a body of work looking at qualitative, and that's what you can see on the slide here, looking at the qualitative experiences from both the physio and the patient perspective. And, you know, the really resounding messages we get from this qualitative work was that telephone delivered care was convenient, accessible, patients felt it was more personal, and that it also empowered their self-management of their condition. There was a desire for visual contact, so that is one of the limitations that's raised with telephone delivered care, and particularly amongst our physiotherapists, and I'll pick up on this later when I get to talking about some of our work in video conferencing. Our physios really were initially resistant to telephone delivery. And I think that's for two reasons. One is because of the telephone, but I think there's also a really strong professional identity. And you'll see a bit of a theme later on that I think there's a little bit of a threat to physios with telehealth in taking away that hands-on approach that they're really used to, and really pushing them outside their comfort zone. And that's what we really found with this study, was that whilst they were really initially quite resistant, once they were forced into this process of experiencing it and actually delivering care this way, their attitudes and perceptions really did change. So those positive experiences are really important. Belinda's also done quite a bit of work looking at our training processes here. And one of the really key messages I think here is that we can't assume that, or certainly not with physios over here in Australia, that everybody knows how to implement person-centered care and that everybody knows how to embed behaviour change techniques and support behaviour change. So we found that those training processes were really important. And even though physios thought they might be able to do that well, by the time they went through their training program, it was only then that they realised what they didn't know. So I think training in these skills is really important. And one of the other criticisms that has often come with telehealth, and particularly, you know, with telephone delivered care, is that you can't build a relationship with the patient. Certainly Belinda's work has shown with our work with this telephone trial that that's not true. We've shown that both patients and physios rated their therapeutic alliance really highly. And although we showed some associations between higher patient ratings of therapeutic alliance with clinical outcomes, these were only really weak relationships and really unlikely to be of any clinical relevance. So certainly these criticisms that you can't build therapeutic alliance, I don't think necessarily are borne out by the evidence. We've also looked at internet delivered models of care, so with a particular focus on video conferencing. And so this trial was one we published a couple of years ago that looked entirely at internet delivered care, with patients receiving a combination of video consults over Skype with a physio over 3 months for a structured strengthening program, also combined with an online pain coping skills training program. And some of you may well be familiar with this. We partnered with Frank Keefe and Chris Rinnie to use their pain coach program here, so that everything was delivered online for the patients that we recruited. And so they had this combination of Skype consults with these 8 weekly pain coping skill sessions as well. And we, you can see from the flowchart, measured this over 3, 6, and 9 months. Looking at our primary time point, which was 3 months, you can see that we showed significant between group differences for walking pain and function that were maintained at 9 months. Again, you can see that dropping off of clinical benefit that really shows that you know, we really need to be working hard to help people maintain these benefits that they achieve at the end of their therapy. We also, this is just a chart to show the percentage of patients who reported being improved overall. So really quite stark differences there between the intervention and the control group. And I should point out that the control group just received internet digital educational pamphlets alone. Again, a number of limitations to this study. We can't work out whether the benefits we saw here were due to the video consultations with the physios or the pain coping skills training. we used limited disclosure to blind patients to our hypotheses, but they didn't, obviously they knew what treatment they were receiving, and the control group realised that they were obviously getting educational information only. And I guess this was more in line with an efficacy study. It was really our first foray into evaluating video conferencing. So it was not really a pragmatic trial. In the sense that each time a patient was enrolled to the intervention, our research staff assisted each patient one-on-one over the phone to actually set up Skype. And obviously that's not easily transferable over into the clinical setting. And we don't know how well people would be able to do that themselves. We did a nested qualitative study in this project to look at patient and physio experiences with the video conferencing side of things. And that paper was published a couple of years ago. And a number of themes came out of that. Obviously, technology is a big issue. People generally found Skype really easy to use, but variable quality depending on their internet connection. And setup assistance was really, really helpful. And I think this is one of the really key aspects to success of telehealth. And we've certainly transitioned in the way that we provide this, helping patients get set up, where we've now moved to providing really comprehensive written instructions with step-by-step guides so patients can work through that themselves now, rather than requiring one-on-one help over the phone. Again, you'll see these themes of patient convenience, with it being time efficient, flexible, and helping them access services that they otherwise wouldn't. Particularly, patients value the home environment and feel that helps them participate in their exercise program much better than when they're prescribed an exercise program in a clinical setting. And from a physio perspective, they really valued the fact that they were focusing and able to focus on the effective treatments for OA, rather than having patient expectations that they needed to have hands-on or manual techniques, and feeling that tension between what the patient wanted and what they know evidence-based practice should deliver. Again, you can see these positive therapeutic relationships. But again, over here, this theme from the physios, where they're really being forced outside their comfort zone to modify their usual habits, and being uncomfortable without that hands-on, and feeling really safe because the research environment provided a safety net. So a bit of trepidation about how they would do this in their normal clinical setting. And here's just a few quotes from that. This one in the pink I really like, from the physios, really expressing that there wasn't any option of getting bogged down with hands-on stuff that wasn't going to ultimately be what the patient needed to self-manage. And this comment from a patient sounds a bit crazy, but it was actually almost more personal than in the past. It felt like the therapist was coming to you in your own home. So at the moment, we've got a big trial running to look just at the video consultations. And this is a night to work out, are video consultations non-inferior to in-person consultations with NeoA? And this has really stemmed from work that we've done with our stakeholders over here, particularly when we've been lobbying for funding for telehealth. The question that always comes back is, but isn't it less effective? And that's what this trial's set up to do. It's the PEAK trial. We're about halfway through now in terms of recruitment, but we're planning to recruit 394 people across largely Queensland and Victoria with OA, and they being, we've got 15 physios involved in the study who give 5 consultations to each patient with the same treatment elements, irrespective of which group they're allocated to. So the program's based on strengthening physical activity, a really comprehensive and integrated educational program that is really built around some key behaviour change techniques around knowledge and capability and empowerment, and supported by a suite of resources, which includes educational booklets, exercise resistance bands, and an activity tracker. And essentially, patients are either randomised to have their consultations via video, we're doing that via Zoom in this trial, or face-to-face in the physio's rooms. As I said, we're almost approaching the 50% recruitment with this trial, so still a couple of years before findings will be known on that one. We've done a bit of work looking at apps, and particularly with a focus on, can mobile apps help increase adherence to exercise? And this study was focused or evaluated PhysiTrack. I'm not sure how widespread that is over in the US, but PhysiTrack's quite widely used over here. And in fact, it's supported by our Australian Physio Association. So lots of physios are using it in clinical practice to help prescribe and deliver an exercise program in face-to-face, but then putting it, programming it into this system. So when patients go home, they've got a digital sort of prescribed suite of exercises with, you can see here, videos and instructions on how to do it. And so in this trial, it was a very short-term trial. We were interested in knowing, well, does this do what it's supposed, you know, what its big aim is, which is to help people increase their adherence to exercise. So we did this trial in 16 clinical practices in Australia and New Zealand, where we just enrolled a mixed bag of patients who were presenting for their first consult with a musculoskeletal condition. And to be eligible, the physio needed to believe that at that first consult that this patient was going to be requiring or would benefit from exercise therapy over at least a 3-week period. And so then if that was the case, then they would be enrolled in the study. And as I said, we were looking particularly at adherence. So we used a series of scales, like you can see here, self-reported for the patients at the end of the study about how much they adhered to the exercise program that the physio prescribed them. The intervention group had their programs prescribed by PhysiTrack. The control group, it was just the physio's own usual care or usual methods, which typically was a bunch of little, you know, here's a handout of exercises on a sheet, or, you know, whatever it may be. I'll give a demonstration, then I might draw some stick figures on a piece of paper. What you can see here, here's our co-primary outcomes, looking at adherence to exercise and confidence to exercise. And you can see that using this mobile app, really it did significantly improve adherence and also significantly improve confidence to exercise as well. Why is that? There's actually we don't know why, there's lots of behaviour change techniques actually built into PhysiTrack. And so you can see, here's a list of the various features in there and how that maps to behaviour change theory. So you can see there's a lot of goal setting, action planning. The videos and text help remind people how to do their exercises. The videos give demonstrations. I think some of the really important aspects of these abilities to record exercise, so it allows people to self-monitor. And what we found with our process measures in this study, that 54% of our patients did use the program to use these recording and monitoring features, and 9% even used the messaging function to contact their physio as well. So it's probably a combination of these techniques that contribute to that increased adherence we saw. We've also looked at using an SMS program to see if we can increase adherence to exercise that way. And this body of work was built off a scoping review we did a number of years ago that synthesised all of the literature out there on barriers and facilitators to exercise in people with hip and knee OA. And it won't be a surprise to any of you that there's a squillion barriers to exercise, but these are the big ones that we found from that scoping review. So lots of issues around lack of knowledge about OA, that people believe they can't do exercise and that exercise is unsafe or wouldn't be good for them when they've got OA. Lots of different environmental issues, and also issues around intention, so particularly lack of motivation. So what we did, building off the back of these barriers, was we used, and this work's been led by Rachel Nalligan, who's almost about to submit her PhD thesis and is focused, her research is focused on all of this. We built a library of behaviour change messages and operationalised it into an SMS program designed for people to accompany a strengthening program that was required 3 days a week participation. And so what happens is the patient gets an SMS saying, "Hi, how many days did you do your exercise?" And the patient responds. And if they respond with less than 3, less than the desired behaviour, they then are invited to input the main reason, the main barrier that they encountered. And then depending on the barrier, we then have a suite of behaviour change messages with tips to help them overcome that barrier. So there's actually a library of somewhere around 200 messages built into the algorithm here to do that. So we tested this SMS program in our ADHERE trial, and this trial was published just last year. We built this off the back of patients coming out or completing another one of our exercise studies where they'd been prescribed already an exercise program from physios and been asked to carry on with that for 3 times a week. And so it was a slightly smaller sample using the sample of convenience that came out of that trial. And essentially the intervention group were given the SMS program, or the others weren't. And what you can see here in the table is that the SMS program, again, we were focused on adherence outcomes, but we see that the SMS program significantly increased adherence to exercise on both of our co-primary outcomes of adherence. What we didn't see though was that didn't translate to differences in clinical outcomes. And it may well be that because we implemented this SMS program quite a way down the track in the maintenance period, we're not quite sure why. There were our qualitative work has helped unpack some issues around the SMS program, and we're currently turning that into a mobile app that is about to undergo some consumer testing, where we're building in some extra features where people can record their exercise progress. They can, we've expanded the barriers because some of our feedback showed that there was another 1 or 2 that patients wanted. We found that with the SMS, we were quite restricted with the number of characters in the messages, and an app gives us more flexibility in the content of the messages that we can give them and the way that we deliver it. And of course, we can now include a tracking feature with a graph as well to really help boost that behaviour change technique of monitoring and feedback. So the app is giving us flexibility with that, and we're hoping to test that in a clinical trial later this year. Rachel's work for her PhD has focused on evaluating the SMS behaviour change messages along with a website of exercises. So essentially a self-administered independent exercise program where the patient works through information on an exercise on the website, particularly with a knee strengthening program over 6 months that's broken into 3 different phases with videos and instructions on how to do it, some educational information to support that, some information about how to increase physical activity, and a few tools for people to help monitor and track their program. And so this is just a little example of some of the exercises and the instructions that are up there on the website. So obviously this is cutting out the middleman, cutting out a clinician. Could this be, you know, a light touch version, if you like, to get patients started on exercise, particularly for those who may not need input from clinicians. And so her trial has combined the intervention comprised this My Knee Exercise website, plus our behaviour change SMS messages. This trial is complete and we've got the manuscript under review at the moment. So hopefully in the next month or so that manuscript will be accepted, and later this year, the findings from this trial will be publicly available. We've also been focusing on looking at e-learning and how can I've talked earlier in the presentation about training physios and clinicians in, you know, upskilling them in evidence-based care. And one of the things that we've been focused on recently is looking and evaluating e-learning models, so using the internet to train people. And this has particularly been done through the PEAK trial, which is the non-inferiority trial that I mentioned a little while ago and said is underway. And in this trial, we actually trained all of our trial physiotherapists via an online program. We built an online or an e-learning modules to teach them about evidence-based knee OA care, to teach them about telehealth delivery, because we needed to teach them how to deliver the intervention via Zoom, and also to actually teach them in the intervention protocol that we wanted to be delivered over these 5 one-on-one consultations. So it really is a package of evidence-based care for OA that can be delivered face-to-face or via Zoom. And we've evaluated that in a qualitative study. For the trial, as I said, we had the self-directed online modules, and for the purposes of the RCT, we then, after the physios completed those modules, we then got them to go through a mock video consultation with one of our research staff, so a simulated patient that was kind of a bit of a gate, if you like, that the physios had to demonstrate competency on a range of things before they could pass through that gate. And then one of the things that we found really important with all of our trials is then to give our trial physios a couple of practice consultations with some pilot patients, really to test all the trial procedures, to practice the interventions, and to do them in the way that we want them to do for the trial. And for the PEAK trial, it was particularly important because all of our physios were inexperienced in delivering care via telehealth. So this was the model of e-learning that we used for that. And what we found was that the physios really, it's quite a different model. Over here in Australia, a lot of professional development for physios is really kind of that old school approach where you attend lectures or workshops, and it's very much face-to-face and hands-on. So this self-directed e-learning approach was really highly valued. The physios liked the fact that they could do it at their own pace. But they also recognise that, particularly with telehealth, having these built-in mock consultation and the practice consultations, so those practical components were really important for them to put that theory and what they learned from the e-learning into practice prior to starting in our trial. And one of the things that we really found was that, we were focused on this for our clinical trial, and we'd started the PEAK trial and trained them before COVID hit. But we were doing these qualitative interviews after the pandemic had started. And so every physio talked about how the training had helped them and really set them up for being able to administer telehealth once the pandemic really kicked off. So then when the pandemic did, we have released these online modules to be freely available to people, to all clinicians anywhere around the world through our website. And we've done a bit of an evaluation. I guess this is a bit more of an outside a clinical trial, but a real world evaluation of what is the uptake with e-learning. And so this data is a little bit old, but we released this program on the 1st of April last year. And this is the pipeline you can see where people have to, unfortunately, it's hosted currently on our university's learning management system, which is a bit clunky, and we're currently transitioning over to another provider. But you can see we've had over 6,500 user requests. We lose about half of them in activating their LMS account and coming through the system. And this is fairly consistent with what other e-learning literature shows, is that you do get attrition through the pipeline, and certainly with web-based clinical research that happens as well. But you can see that we've had over 2,500 people engaged in our modules, and we've built in pre-training and post-training surveys there, and then fairly quickly started implementing a survey out to our people who complete training 4 months later, just so that we can start to glean some information about, well, are they actually using what they learned in this program? What features, what aspects of the e-learning has been valuable, and how's it being used? We've been amazed by how many people we've reached, 97 countries, with our top 5 countries you can see here. And it's really been a really big snowball effect with, people, word of mouth through work colleagues, social media. Professional physiotherapy organisations have really been big on disseminating this, I think particularly because of the telehealth components to training. Again, similar to what our data shows over in Australia, that this is a question that we ask people prior to training, and that you can see the vast majority of users coming into our program have never offered video conferencing to their patients before commencing training. And when we look at people's confidence to use video conferencing, this is again pre-training, you can see people aren't very confident at all with only, you know, if we just dichotomize it into 8 and above, this using an NRS, only 22% scoring 8 or above beforehand. But that really shifts after training, where you can see scores are really moving up, where 73% of people, of our people completing the program, are scoring 8 or above. This is just some data from our 4-month survey about how much did people find the e-learning helpful, and did it inform your practice. And I just point out that we've had people, not just clinicians, but also quite a number of students and people involved in education as well, doing the training. And you can see half of people have said that it really has informed their practice, whatever it may be, to a moderate extent, which is really pleasing for us and has really been, I guess, a really nice side benefit. We hadn't intended to spin this off from our PEAK trial. It might have been something that we're thinking about way down the track, but of course, you know, COVID presented an opportunity, and so this feedback and this real world experience is really valuable data, I think, at looking at e-learning. So I'm going to finish up there, so we've got plenty of time for questions. I would point you all to this is our website. We've just revamped our website at our Centre for Health, Exercise and Sports Medicine, but pretty much we do put most of our resources that our research develops for patients and clinicians, we typically make it freely available, and usually through our website. So you'll find things such as, for example, links to the PEAK e-learning that I just talked about. That's free. You can register for that through our website. Pain Coach that I talked about, that had been developed by Chris Rinnie, we have now developed it and rebadged it for an Australian context and released that free of charge for clinicians and patients on our website as well. You can find links to the My Knee exercise website that I talked about from Rachel's PhD on there, as well as a range of other things as well that may help some of you with your research or in your clinical practice. So I might stop talking there and stop sharing my screen.
Okay, so thank you so much, Dr. Hinman. So we do have time for some questions. So just to remind everybody, you can type your questions into the chat box, or you can unmute yourself to ask your question directly. And we do already have a question in the chat box that I'll go in and read out loud so everybody else can start thinking about their questions. Could you please comment further on the behavior change training? Very interesting to have offered in addition to the protocol.
Sure, yeah, that's a great question. And it's a really tricky one to do. So do you want my video on, or, oh, I can't turn it on. I'll answer. So we've done we've had a couple of different approaches, and with the 2 trials I mentioned there, we have partnered with an external provider. So we have there's a company, a provider over here in Australia called Health Change Australia, that was set up by behaviour change by a health psychologist a number of years ago. And that company was set up basically to help clinicians with person-centred care and behaviour change support. So it's not, whilst it touches on the theoretical components, it's essentially a consultancy service that helps people embed behaviour change techniques into their practice. And so we partnered with that company in both of those grants to get them to train our clinicians. And it's quite an extensive training process, which is which is great. But on the flip side, it can also be a bit of an implementation issue, in the sense that it took 3 months to train the physios. They had to go through a number of workshops and then do a lot of practice with their own patients. We have recently switched to, in one of our other trials now, again, engaging with an external provider, because we're not health psychologists, where the external provider trains our clinicians in motivational interviewing techniques. And typically that might be sort of a day workshop. So we're kind of switching down to that. But I think what we've done in the meantime, you could say, oh, we're reducing the amount of training we're doing. I don't think we necessarily are, because in the old, with those original trials, when they were getting that really intensive training, our treatment protocols didn't necessarily embed those behaviour change techniques in there. Whereas now we do that, and simply if the physios are following or sort of adhering to our protocols there, and we have scripting within our notes, our consultation notes, that simply forces them, well, not forces them, but by following that, they're actually doing the behaviour change techniques. They're checking about barriers. They're asking patients to action plan and consider what do you think is going to make it difficult for you to do your physical activity plan we've just talked about. So we've moved from a process to trying to embed as many of those behaviour change techniques into our patient resources, using apps, into the way our physios discuss it, plus also some external training in some of those skills as well. So that was a bit of a long answer, but hopefully that answers the question.
And we have another question from Dr. Allen. So what are your thoughts or guesses about best telehealth strategies or mobile tools for helping to meaningfully engage in activity over the long term?
Yeah, look, that's a really good question. I can't think of any research that's really looked at teasing out, is one tool better than another? And I think it was only just recently I think there's a systematic review that's been published in JAMA looking at, if we think about tools and physical activity, looking at wearables and step counters, Apple Watches and the such. It certainly did show that those sorts of activity trackers do increase physical activity. So we certainly encourage that and embed that within our trials for if one of the goals of our interventions is to boost physical activity, we will be encouraging tracking and monitoring, and so therefore using whatever devices that people have available. If we have grant funding for a study, we may provide that. I think that the evidence is really starting to emerge that mobile apps are helpful. I think I presented some data with that, with encouraging adherence. I think that the thing to be cautious about is there's loads of apps out there, and loads of them are not based on necessarily any evidence or behaviour change theory. So it's really about picking and choosing those ones. And really, I think as researchers and clinicians, really scrutinising those apps to have a look and see, do they really contain those behaviour change techniques that we know help? And I think it's really about understanding what is the behaviour we want people to do, and therefore different tools may be needed for different behaviours. For example, if we're trying to support people to lose weight, they'll be needing different digital tools than if we're trying to support an increase in physical activity and a reduction in sedentary behaviour. So I think that's something that we try to think a lot more closely about now, is what is the behaviour we're trying to change? What are the barriers to that, and how will be the way to meaningfully overcome that? But we will always take a person-centred approach, and what might be useful for one patient might not necessarily be useful for the next one.
What do you see as some of the barriers to telehealth in Australia?
It's a good question. Look, I think probably the biggest barrier to date here, no surprises, has been the lack of funding for it. So, as I pointed out, there was no private health insurance funding, no government funding. So there's been no incentive, I think, for clinicians to offer it or set it up. I think that's changing, and I think that will change. Our government has made media announcements saying that telehealth is here, telehealth funding is here to stay throughout Medicare. But pointing that out, there's actually very little Medicare support for physiotherapy services over here. But certainly the talk from our private health insurers is changing as well. And I think they're going to encounter resistance about taking away something that's now been around for a year, and that's funding. So I think hopefully that barrier is starting to be broken down. I think my perception actually is I think clinicians are probably the biggest barrier in terms of being resistant to change. We've collected data throughout the pandemic doing a survey, a range of surveys actually with physios over here, but also more broadly in allied health. And also within our National Disability Insurance Scheme recipients, looking at clinician and patient perspectives and perceptions of telehealth. And what we typically find is that the patients view telehealth far more favourably than the clinicians. There seems to be a resistance from clinicians, and I think part of that is related to it's hard to change habits. And certainly bringing telehealth into your work setting does require quite a bit of structural change, if you like, and workflow change with, integrating how do you bill patients, how do you set up appointments, and all of those aspects. But I think it's also this professional identity. And, my perception is certainly when we look at a lot of the quotes that we receive, from in our qualitative interviews, and I've just seen a paper, another survey published last week that had a range of physio perceptions. There's this threat. People seem to think that if they embrace telehealth, it's going to take over and we won't have any more face-to-face care. So I think there's a bit of, I think we need to, I don't see telehealth as a substitute for face-to-face care. I see it as an add-on, or it should be an option there so patients truly can choose what suits them. And it may well be for many patients that a blended approach is the way to go, that, there'll be some face-to-face visits and then telehealth can support or do many of the follow-ups. And so I guess the other barrier that is related to clinicians, I think, is that lack of training. I can't comment in the US, but certainly over here in Australia, amongst the physiotherapy degrees, telehealth has not been something that gets much airtime at all. That's probably changed a little bit because the pandemic has highlighted those weaknesses. But I think the other fear amongst clinicians is I actually don't know how to do this and I don't know how to do it well. And so I think we need to be much better at upskilling and training our clinicians in how to do really good telehealth services, as opposed to here's something that I've just had to do overnight because, I'm now in lockdown and I can't deliver. I can't see my patients face to face tomorrow. And that's unfortunately what the pandemic over here really, really forced upon everybody.
So it looks like
there's a question, what opportunity is there to move? Sorry, did you want me to go to that question?
Oh, by all means.
Yep, upstream to physio training programs. So these approaches become the norm, not the exception. And look, I think it's a really good point. I think one of the biggest difficulties, certainly, I'm a researcher, but I'm embedded in a department where we have a DPT program. One of the biggest issues is how jam-packed the curriculum is. And trying to squeeze something new in, it means it usually has to come at the exception of something else. But we've seen that happen certainly within our course over the last year. It's been necessitated because we've been hampered. For a large chunk of last year, where I am in Melbourne, we're in lockdown for about 3 or 4 months, and our students could not go to clinical placements. That was different to the rest of the country because the rest of Australia didn't have a second wave. And so in order to offer clinical placements, our university degree had to build in telehealth. And in fact, they used the PEAK training program that I talked about, and then use telehealth consults for their clinical placements. So I think that will happen more, and I think there's lots of opportunity there. But again, we've got to build that knowledge base and that skill set. And I think a lot of educators don't know how do we go about teaching this? How do we do it? Are there good clinical settings out there that are doing great telehealth that are models for teaching our students? But I think it's something that the profession has to address. And it's not unique to physios either. I'd point out, all clinicians have been in the same boat.
Okay, so it looks like we have another question. Would you please talk a bit more about how you promoted the mobile app and then encourage people to actually use it?
Yep, so I talked about 2 mobile apps. So the one that we used in that completed clinical trial is PhysiTrack. That is something that it's basically, it's not just an app, it's part of a web-based programming system that I believe the way it works is the clinician or the private practice subscribes to it, and then they can hook on as many of their patients as they like. So in that study, it came from the physio themselves as they were prescribing in the clinical consultation. You know, I want you to do these exercises, and I'm going to give you, I'm going to send you the link to this app, and I'm going to prescribe it here. Obviously, for patients need to have a device that connects to it. So it came through the clinician as the enabler of that. With the app that we're currently developing, that's not out there yet. We're still working with the tech team and doing some prototype testing. But basically, we intend to, when that's available, that will be released we intend to make it free. And then we want to evaluate that in a clinical trial, but, you know, our vision is to then look at disseminating that through our consumer advocacy organisations, but then particularly also through our Australian Physio Association, so that physios can be then encouraging their patients to download this app, which will provide those behaviour change support messages to help them stick with their exercise program.
We have another question. So how well has your app reached diverse patients, such as rural, urban, racial, ethnic diversity, various economic statuses?
Yep. I can't comment on the app that we're developing yet because we haven't pushed it out there. And I'm just trying to think of what data we might have from the PhysiTrack app. I mean, that's used pretty widely over here in clinical practice in Australia. As I said, it's something that the company that created it sought endorsement from the APA. And I think one of the reasons it's had such good uptake is, I think if you're an APA member, you actually get a cheaper rate to use this PhysiTrack app. And so I think you would find that it has had quite good reach. However, it is only in English language, so I would put a caveat there with I doubt it's had much penetration into, you know, non-English speaking communities. And given that app is largely promoted from the physiotherapist, it will only be reaching those, and it's requires the physiotherapist to prescribe and pick the exercises. It's only reaching those people who have had access to and can afford to see a physio for face-to-face care in the first place, which is one of the reasons why we're trying to build our app so that it can be used to support a patient who's just at home and who may have their own program, or for example takes their own prescribed program off our website and then can just use this app and download it themselves without requiring any clinician input. So that's our to try and overcome, to get those increase the access that way. That's how we're planning to disseminate it.
Great, so it looks like we're about at time. So I'd like to say thank you again, Dr. Hinman, for taking the time to talk to all of us today. I'm gonna be sending out a follow-up email to everyone in the coming days with a link to access the recording of this talk in case you would like to listen to it again or share it with your colleagues. Prior to everyone leaving the meeting, it would be great if you could complete a brief anonymous poll about the presentation. I believe it should be active right now. And thanks again to everyone for attending the talk. I hope you all have a great day.